All right, thank you everyone for joining us today. Today we will be discussing how to collaborate with others in the care community. This is the Practice Transformation Webinar Series, Session 4. We did intend to discuss patient engagement in this session, but we have moved it to the next session because the session ended up being very long. And I'm going to throw it to Gary for these instructions.
You joined the meeting today unmuted. Please mute your audio. You can click the microphone icon at the bottom of the screen to do that. To unmute, click the microphone again. And as a reminder, if your icon is green, you are unmuted. We do encourage questions during the session. If you would like to use the chat function on the right-hand side there, make sure the drop-down says to everyone and enter your questions there. We will attempt to answer those questions at the end of the session.
All right, thank you, Gary. Now a little bit about this series. Each session will be no more than 30 minutes long, as we know that time is a precious commodity. Each session will have time at the end for open discussion and questions. Because this is a small bite series, we will cover 1 to 2 foundational elements of practice transformation in each session. By taking small bites with each session, this will allow you to take small incremental steps in your practice. This series is designed with the small practice in mind, knowing you have limited personnel and financial resources. These are the steps of practice transformation. These steps are not in any particular order. They are really all done simultaneously. However, identifying your patients is the first step and was covered in our second webinar. Now, don't let this list scare you. It's important to note that your practice could implement only a few of these steps and still effect change. It's not all or none, but the more invested you are in the change, the more impactful your outcomes will be. Today, we will cover collaboration. Previous webinar recordings are available on our website. As we advance in this webinar series, we are working towards the quadruple aim, particularly better outcomes at a lower cost. Just a reminder that lower cost does not mean less care, just care in the right setting and at the right time. And if we improve outcomes, then long-term expenses should decrease. So let's start our session today by looking at a definition of team-based care and how that includes collaboration. This definition is from the National Academy of Medicine, and it defines team-based care as the provision of health services to individuals, families, and/or their communities by at least 2 health providers who work collaboratively with patients and their caregivers. In the last session, we talked about team-based care, but focused on the team within your office walls. Today, we will focus on the team beyond your office walls. Team-based care acknowledges all the players involved in achieving maximum health for your patients. The patient is always the central member of the care team. Care team members outside of your office include other medical professionals, such as specialists in hospitals. Another member of the care team that we often forget is those community resources, such as community health workers, food banks, senior centers, and the like. They can help you address the social determinants of health. Everybody in your community plays a role in the health of your patients and the population and must all work together to achieve the best outcomes. So why is this important? We all know that your practice is not in a bubble. You share the care of your patients with others in the medical community and with your community as a whole. By collaborating with local hospitals and specialists, you have the potential to avoid duplication of services, improve communication, and ultimately deliver more comprehensive care to your patients. By collaborating with your community resources, you can better address the social determinants of health. So in my experience working in a hospital and a clinic, this is how referrals often work. First, the provider identifies a patient that needs to see a specialist. Then the provider selects a specialist based on previous experience, convenience, or maybe it's a buddy from med school. The staff calls and schedules the patient, or alternatively, the specialist office will call the patient to schedule. Next, the patient visits the specialist. They may or may not receive additional testing ordered by the specialist. Then, after the visit, a summary of the visit is sent to the PCP. Now, we all know that this process does not always go smoothly. For instance, how many times have you called the specialist for a referral, yet the patient never receives a call back from them to be scheduled? Or the patient gets to the specialist's office only to find out that they needed further testing before their appointment. This can be really frustrating for patients. How about when that patient comes back into your office weeks later and tells you about all the new meds the specialist prescribed, but your office never received a report and didn't know the patient was on any of these meds? This can lead to provider dissatisfaction. Luckily, there are ways to improve the experience for both the patient and the provider. So I doubt many of you have a written protocol with a specialist regarding referral processes. Some of your staff may have knowledge of specialist preferences and incorporate it into their communications, but probably it's not actually written down anywhere. A collaborative agreement puts into writing those informal agreements and processes that you have in place. As we talk further about collaborative agreements, it should be noted that we're not saying that this is a legal and binding document. Rather, it is putting down on paper expectations and workflows to improve communication, collaboration, and provider and patient experience. Of course, there needs to be a reason to have this kind of an agreement. So why is it important to not only your office, but to the specialty? First and foremost, it increases communication and it really clarifies the expectations of both parties. It can lower costs by eliminating duplicate testing. If you establish follow-up protocols, it could alleviate administrative burden of your staff who monitors for those follow-ups. And most importantly, it improves the patient's experience and quality of care as well as their safety. As you think about reaching out to specialists to explore this option, consider this an opportunity to strengthen the relationship you already have with the specialist, again, with the goal of improving patient care. As you're developing a collaborative agreement, consider what should be included. First and foremost, you should establish what patient information is needed so as not to delay the appointment. These can include the diagnosis, the urgency, and the clinical data. But also consider if there are specific diagnostics that the specialist always needs that your office could order so that the specialist has the results at the time of the appointment. I know where I worked before, our hospital could do ultrasounds. So if we were sending a patient to the neighboring city to see a cardiologist, we could often do echoes in our clinic, or if they were seeing a GI, we could do an abdominal ultrasound. Next, what are the expectations for access and scheduling? How soon should your office expect to get a patient in based on the urgency of their referral? Who schedules the patient? Is it your office or does their office call? If the specialty office calls the patient, how soon should the patient expect a call from that office? And then which office determines insurance eligibility? Next, who communicates with the patient and prepares them for the visit? Perhaps a specialist could provide your clinic with information that you can share with the patient to make their appointment more effective. And then how soon should your office expect the office visit notes? And how will you receive them? If you have the potential for an electronic exchange, perhaps you could establish that process. So here's a sample of a collaborative agreement so you can get an idea of what it looks like. There's a second page to this also that I'll show you in just a second. I want to note that this agreement clearly delineates what each office will do to ensure an effective and efficient specialty appointment. So in this case, the primary care practice is agreeing for how they will prepare the patient, what information they'll provide, things like that. And this is the continuation of that agreement. And again, note that there's no signature on this agreement. It's a document that's not legally binding, but yet it clearly states the expectations of each party. Now let's revisit that referral process to see how it could look with a collaborative agreement in place. So let's consider a patient that needs to see a cardiologist. First of all, the cardiologist is selected because the office has a collaborative agreement in place which means the staff from both offices know the expectation of the other, making scheduling of the visit much smoother. The collaborative agreement established the expectation that an urgent patient would be seen within 72 hours. So the patient was scheduled for a visit in that time frame while they were still in the PCP's office. The PCP office knows exactly what patient information the cardiologist needs for an efficient and effective visit. So they send that information electronically per the cardiology office preference. They also know that the cardiologist needs an echo in order to make treatment decisions for this referral reason. So the PCP office goes ahead and ensures that the patient receives that imaging prior to their appointment and that the results are sent to the cardiologist. Your staff also knows that the cardiology office has an online form that new patients can complete prior to their appointment. So that information is provided to the patient to save them time the day of the appointment. Once the patient gets to the office, they just breeze through registration because they filled out all that information on the patient portal, and now they just have to verify it. The cardiologist is happy because he has a thorough patient record and the echo, so he's able to diagnose the patient that day and develop a treatment plan with the patient. The cardiologist creates a visit note, and again, since you've established an electronic communication expectation, the note is sent to the PCP as soon as the cardiologist signs it. Now with this note, the PCP knows their role in managing this patient's condition as well as the new medications that they were prescribed. Now the office staff can update the patient record with these new meds in preparation for the next office visit. As we revisit this slide, we can see that the workflow we just discussed serves all of these purposes. Because of the collaborative agreement, the expectations were set of who communicated what to the patient and how the PCP would be updated on the plan of care. The echo was obtained and sent to the cardiologist, so the patient did not have to return to the office later for development of the plan. This saved the patient time and money. Because the office has established an electronic form of communication, the PCP was able to receive the cardiology visit note directly and in a timely manner. And most importantly, think about how this experience was for the patient. They had all their paperwork and testing done in advance, so their visit could be very smooth and productive. So let's now discuss how to begin this process with a specialty provider. Our practice transformation team can help you assess what you want out of a collaborative agreement and guide you through the process if you need assistance. The first step to implementing collaborative agreements is to identify who it makes sense to have an agreement with. It would be good to start with a specialist who you already have a good relationship with already, who would be open to just formalizing a workflow. Alternatively, it could be a provider that you are just beginning to refer to as a way to get off on the right foot. Now, reach out to them and ask them what their expectations are of your office when you make a referral. This lets them know that you're creating an agreement that's to their benefit as well as yours. Now, your office staff and their office staff can collaborate on scheduling and follow-up timeframe expectations and talk about how those processes will happen. Next, you should record this in a document that's shared with the specialist office and your staff. Make it accessible to your staff so they can reference it when making a referral to ensure all steps are taken to make the experience as smooth as possible for both the patient and the providers. Now, in a perfect world, you'd have a document like this for each specialty office. However, we know that's not going to happen. So start with one specialist, see how it works, and then build from there. Now, we need to think about measuring success. The first step to measuring success is to decide what part of the referral process is not working well right now and monitor it for improvement. For instance, does it take 3 phone calls in 2 days to get a patient scheduled with the specialist? By enacting a collaborative agreement, these processes are outlined with the intention of improving that process. So, does it take less time after the collaborative agreement is established for your staff to get that patient scheduled? Then think about, are the specialist appointments more efficient? You could assess this by reaching out to the specialist after a few patient visits to see if they're able to conduct more thorough initial visits. Looking at follow-up, Does it take a week to get back to get the office visit note back from the specialist currently? After implementing a collaborative agreement, monitor the time it takes to receive that report and see if the time is shorter. And then, of course, we need to think about the patient experience. Follow up with your patients you've referred and get their feedback. Are you hearing positive feedback from them? So those are the points for specialty collaboration. I want to stop now and see if anybody has any questions before we go on to hospital collaboration.
I don't have anything in the chat at the moment.
All right, perfect. Well, feel free to chat in any questions you might have, and we'll address them at the end. So now we're going to move on to hospital collaboration. I'm sure that all of you have some form of communication with the hospitals that your patients frequent. However, collaboration moves a step beyond that communication. So communication frequently consists of admission, discharge, and transfer fees, which are also called ADT fees. You probably get hospital discharge summaries, and if you're lucky, you also get emergency department records. Additionally, some of you may have access to your hospital's medical record. Collaboration takes that to the next level by involving your team in the patient's care while they're actually in the hospital or ED. So many of you may actually already follow your own patients in the hospital, and if you do, you already are having some level of collaboration with the hospital. However, there may still exist some opportunities to collaborate further. For example, you might have a patient that tends to frequent the ED for non-emergent issues. So think about that patient. Can you work with the ED staff or the hospital social worker to maybe develop a plan with the patient to avoid those inappropriate ED visits? A consistent message from both your office and the ED might have an impact on that patient. How about those patients that are hospitalized? Right now, you may get a discharge note. But what if they need a follow-up appointment within a couple days of discharge and that note doesn't come for a week or so? By establishing a relationship with the discharge planners in the hospital, you can help to ensure that those visits don't fall through the cracks. Additionally, if you communicate with the discharge planners during the hospital stay, your clinic may be able to offer some insights about that patient that may impact their discharge plan. Now think about those patients in swing bed or patients that have been hospitalized for an extended period. They're very likely having care team meetings on a regular basis with the discharge planner and social worker. This is a great opportunity for your clinic to be a part of that patient's care while they're still in the hospital. Consider having a staff member attend those meetings so you can assure your care team knows what is happening with the patient and how you will impact their care after discharge. So I want to preface this slide by saying that how this process works is going to be very dependent on the hospital you're working with. In my experience, I found that this is much easier with a smaller hospital because there are fewer layers of authority to go through. In a larger hospital, this can be a real struggle even finding the right person to talk to. Again, our practice transformation team can assist you in this process. Gary is our health IT consultant, and he also can assist you with establishing data feeds if you need assistance with that. So on that subject of data feeds, if you don't have a data feed already established with your local hospital or ED with ADT notifications, that really should be your first step. And yes, I know it falls under communication and not collaboration, but if you don't know your patients are in the hospital or have been in the ED, then it's going to be impossible to collaborate. In order to collaborate further with hospitals, again, it's important to find that right person that can implement the change. To establish a data feed, that could be someone either in health information management or IT or perhaps both. For inpatient or ED collaboration, a really good place to start is the director of case management or the director of social work. Once you have a contact established, you should work with that contact to identify really the level of collaboration that makes sense for your practice. This may look different for different kinds of patients and even vary by hospital unit. For inpatients, that level of collaboration might be a phone call to your provider's nurse on the day before discharge for a warm handoff and to schedule a follow-up appointment. For a skilled or swing bed patient, this might mean your staff dialing into a weekly care plan meeting or even attending in person, or maybe just making sure that those care plan meeting notes are shared with the provider on a weekly basis. For an ED patient, again, this is likely going to be on a case-to-case basis. For instance, if the ED identifies a patient utilizing the ED inappropriately, they may reach out to your office to develop a plan with that patient to avoid those visits. And since all of this is likely a new process for both the hospital and your clinic, it's really going to be important to have frequent feedback from both entities as well as evaluation of how the process is working. So we always want to measure success. So if you're establishing a data feed, you'll want to ensure that you're receiving all of the notifications you should in a timely manner. You'll need to work very closely with the hospital to ensure this happens, and honestly, it's probably going to take quite a bit of trial and error to refine that process. And looking at evaluation of inpatients and ED patients, again, the evaluation might be different for collaboration based on the type of patient. So if you've established a contact protocol for inpatients, you could assess the number of patients discharged and evaluate if you received a phone call for each of those patients prior to discharge with follow-up needs and to schedule an appointment. If you've decided to include your staff in swing bed care plan meetings, you could assess how often your care team was included in them, or alternatively, how often you received notes related to those meetings. And then for ED patients, this is going to be harder to evaluate, again, because it's likely on a very case-to-case basis. But as you're collaborating on a certain patient, you could really compare the rate of unnecessary ED visits before and after the intervention. All right, any questions on ED and hospital collaboration before I move on to community collaboration? Okay, perfect, thanks. So let's talk a bit about why community collaboration is important to your practice and patients. So this slide is the county health rankings model. And this graphic indicates that clinical care contributes only 20% to the health factors that actually impact health outcomes. Social and economic factors contribute twice that much at 40%. So no matter how great the care is that you deliver to the patients when they're in your office, in your building, if their basic needs are not met, their health outcomes will not improve. The remaining health factors are healthy behaviors and physical environment. All of the factors that are outside of clinical care are called the social determinants of health, which is a term I'm sure you're all very familiar with, especially in this time of COVID. Your practice itself cannot meet all the needs of your patients. However, you very well may have resources in your community that can meet many of those needs. So this is where community collaboration becomes so important. First of all, do you know what resources are available? Do you have referral processes in place for each of those organizations? And how do you know your patients have accessed those services once you've referred them? So there's not enough time today to tackle all the social determinants of health. So let's focus on just a few. As you look at these three needs, which are unfortunately very common, especially right now, be thinking about the resources you have in your community to support them. So food insecurity isn't about just a lack of food due to inability to pay for food. It is also about a lack of access to food or a lack of healthy choices. If someone lives next door to a convenience store, but 5 miles from a grocery store, and they don't have reliable transportation, they're likely accessing that not so healthy food from next door. So even though they may have the financial resources to purchase food, they don't have access to the healthy food and their choices are restricted. When we think of housing, we often think of those who don't have a place to live. But housing also includes those that can't pay their utilities, so they may not have running water or electricity. Or they're in danger of eviction because they're late on their rent. Or often the housing is just frankly substandard. And as we discuss transportation, the lack of reliable transportation impacts people in many, many ways. For instance, They may have trouble getting medical appointments or to the grocery store, as we just mentioned. However, they may be unable to keep a job because of lack of reliable transportation. So I'm going to talk about the steps to implementation for all resources, and then we'll talk a little bit about specific ones in the next slide. So your first step is really to find out what resources are available in your area. So a great source of this is both Aunt Bertha and United Way 211. I only recently heard of Aunt Bertha, but it is a list of resources by zip code. United Way 211 is also available and is listed by United Way service area. And remember that your staff probably knows a kind of under the radar assistance program, such as local churches or other organizations. So as you build your resource directory, you want to focus on those that are most relevant to your patient population and verify that they are in fact serving people in your area. The last thing you want to do is refer someone to an organization that's no longer in existence or your patient isn't eligible for. And since we're talking about collaboration, you should decide what resources you will likely access the most and look at how to build a referral process with them. And the most important step in my mind is to know up front who each agency serves and what documentation is needed. Again, you don't want to send someone to a resource only to find out that they need proof of income with them and they don't have it. The intention is really to make the services easily accessible to our patients. Now, some community resources will share with you if the patient actually accessed their resources, but some won't. So if you can establish some kind of follow-up, that would benefit your patient. For instance, you may assume that they accessed the food resource you connected them with. If they didn't, they're likely not going to share that with you, so you may never address it again. You may just assume that they accessed it. So if you know they didn't access it because the resource followed up with you, then you can talk to that patient about the barriers and why they were unable to access it. And this resource directory that you create should be available to all your staff, because the patients might need to actually have a need identified prior to the visit, such as a lack of transportation to their appointment. So with this info at their fingertips, your registration staff could go ahead and make a referral for transportation. And remember, this is an ongoing process, so you really should update your directory regularly, perhaps every 6 to 12 months. And the update could be a verification of resources and then just kind of a touch-base call with those that you use the most. So this is a partial list of resources that I found when I used Aunt Bertha to search for resources in my hometown of Holton, Kansas. So again, I only listed the ones that were most relevant. There was a multitude of resources listed on Aunt Bertha. So if I were working in a clinic and I were thinking about who do I want a collaborative agreement with, I would probably reach out to the food pantry. Since it's a local food pantry, Harvesters is not local. And it's interesting in looking at this list of resources that I knew from my experience working in the hospital as a care manager that there are 2 other transportation services available locally that are not listed on Aunt Bertha. So again, those would be the ones that I would probably utilize first, mostly because I've used them before and they're local. So that's why I recommend that you tap into your staff for those ideas, because again, this didn't show up in that database. I want to note that for your patients with Medicaid, the Medicaid MCOs do offer transportation services, so be sure to reach out to them first for your patients with Medicaid. I also want to note that many payer organizations are working hard to address health-related social needs. So if you can't find local assistance for your patients or the need is more long-term, you should consider reaching out to the insurance to see what support they can provide. Again, the Medicaid MCOs have really increased their support in areas of social needs in the last few years, and I encourage you to reach out to your MCO reps to get a better understanding of how they can help you support your patients with these needs. Now, again, there was a multitude of other organizations listed on the website that weren't local but could still assist patients. So again, it'd be good to include them in a resource directory, but maybe not so important to establish a collaborative relationship with them. And then as you're considering collaborating with your local resources, assess how your practice can also contribute to that organization. So thinking about if you're collaborating with harvesters, could you organize a food distribution in your parking lot? Or if you're collaborating with your local food pantry, could you have a food drive for, within your practice with your staff? Because collaboration goes beyond just referring patients and closing that referral. It really is working together. So again, let's talk about how to measure success. So the first thing is, if you don't already screen for social determinants of health, now would be a really good time to implement that. Again, this is definitely something that our practice transformation team can assist you in, as it often involves a process analysis and probably some tweaking of your health IT. So once you begin screening, you can run reports of how often a need was identified and a referral was made. Additionally, you can see if the rate of a particular need decreases over time to assess if your community is meeting that need. Another way to measure success would be to track referrals for community needs if you don't already. So if you do already track them, are you assessing follow-up to the referrals? If you begin to track them, ensure that you have a way to document that follow-up and then measure how many patients actually follow through. Of course, again, you may not be able to get follow-up from all your resources. So consider touching base with them to assess if patients come to them from your clinic with everything they need to access services. This will allow you to refine your process and update your resource directory. And then always a great way to assess success is through patient feedback. The whole point of these referrals and collaboration is to ensure that the patients have the resources they need outside of your office. By seeking that patient feedback, you can determine not only how the process works for them, but really if it's making an impact in their life. So let's talk about next steps. There are many small steps you could take to implement any one of the ideas we discussed today. So think about what works best in your practice. So could you choose a specialist to reach out to for a collaborative agreement and get that process rolling? Or is there a hospital you'd like to collaborate with more? Could you reach out to them and establish a process for future collaboration? And then how about building a resource directory and reaching out to at least one local resource to establish a collaborative relationship? I'm sure there's an organization out there that would love to partner with your clinic to impact the residents of your community. These actions will go a long way towards improving the care that you and your community deliver to your patients, which will have an overall impact on their lives. And again, Gary and I are always here for assistance, so we would love for you to reach out to us for this. And then, Gary, I think I saw a question pop up, so I'm going to go ahead and let you, I don't have my chat box open. Can you read me that question?
Yeah, Vicki asked if we had a good tool for screening for social determinants.
Yeah, that's a great question, Vicki. So one of the, a great organization is Health Leads. They have a great social determinants of health tool. Their tool is very lengthy, and it covers all domains of social determinants of health. So what we often recommend is that you look at all of the domains and you pick which domain is most relevant to your community. So if your community maybe does fine with housing, but really you have a lot of people who have food insecurity, then maybe you could take 2 questions from the food insecurity domain and ask every patient that question at check-in. Because if you were to ask the whole social determinants of health screening, it would take like 15 minutes. So it's nice to kind of look at those questions and just parse out the ones that are most relevant to your practice. Or you could choose a couple, and you can kind of just weave those into conversations with the patients as you're rooming them.
I think that's it.
Okay, and when I send out the information, probably won't get it sent out till Thursday, the follow-up information from this webinar. I will send a link to Health Leads to you, or I will send the tool, one or the other. All right, let me go on to my next couple slides then. So again, we love to assist practices in practice transformation. Our consultation services are free for practices that are contracted with at least one of the Medicaid MCOs. So if you're not contracted with an MCO, we do provide that service on a fee-for-service basis as well. And then Gary is going to post a link into chat of our web page that lists all of our practice transformation services that we offer. It also has, within that page, it also is going to have the links to our previous recordings of our other webinars. And then our next session is on December the 1st. So this session, again, we didn't have time to cover engaging patients in their care, so we're going to cover that in the next session. And then we're going to talk about using data to drive improvement. We know that you guys get a ton of data, so we're going to help you to kind of prioritize that data and know what data is the most relevant and how you can use it to drive improvement. So we're really looking forward to that session. And this is our team. This is my email and Gary's as well. And then we really want to know from you what we can do differently and what we're doing well. So Gary just posted a link to the survey. If you'll literally takes less than a minute. If you would complete the survey, we would really appreciate your feedback on the session today. And with that, we will close the session. Thank you all for attending. Appreciate the questions and hope to hear from you all soon and hope to see you at our next session on December 1st.
Thanks, everybody.
Thank you.